Nehal, Nehal ma'am, would you like to start the session?
Sikha, you can start. So, of course, before you start, I will only introduce the faculty expert for today. So, welcome everybody, all the postgraduate students, and I can see many other senior practicing pediatricians also who've joined. So, welcome everybody. A very good evening. And today's class is going to be on approach to common pediatric rheumatological conditions, a case-based study that is going to be taken up by none other than our secretary, IAP Mumbai, Dr. Sikha Agarwal, who's a pediatric rheumatologist. And as I see that she's insisted everybody to keep the videos on, she is a PGI Chandigarh postgraduate. She's not going to spare anybody. So please listen to her and you're going to have a wonderful learning. She's an extremely good clinician and she's really going to give you some important points, which is going to be a kind of a nutshell learning about pediatric rheumatology. So without wasting much time, over to her. And yes, Sikha, you can start the session.
Thank you so much, ma'am. Thank you so much for this kind introduction. So before we start, just disclaimer for everyone that it is more of a very postgraduate oriented talk. So on a topic of juvenile idiopathic arthritis. So I'm just trying to cover topics where there is an exam oriented long question or short question which comes on juvenile idiopathic arthritis, and when there is a long case or short case where you have to do a PGALS examination. So both the topics. You can see me in two devices, one where I'm sharing my screen and one when I'm actually visible. Okay. So the screen will show it is like a board kind of a stuff where you can see what you can see the whole slides and everything. Okay. And I would again request as far as possible the postgraduate students to keep their videos on so that I at least feel that I'm talking to someone rather than just a blank screen. So it will help me to interact better and it will help you to learn better. Okay. So we will start with this. So the first thing, the whole thing that we are going to cover in this is a PGALS examination, JIA, Juvenile Idiopathic Arthritis, which can be a long question and short question both. Both I have gone through the question banks of DNB papers and everything. So where JIA comes as a short note also, each individual parts of JIA also comes as a question. And a few, just one or two cases, we'll try to discuss how, if you get in an exam, how will you go? So coming first, let's get into the mode of the joints. So you see here a picture where you see there is one is the joint thing that is there. So the joint capsule, the cartilage, the joint space, the synovial membrane, which actually makes the joint. And the rest of the structure are the periarticular tissues, the muscle, the bursa, the tendon, the enthesis. All these are important because when you see a patient who is complaining of joint pain, you need to find out whether it is an articular pain or it is a periarticular pain that you are seeing in that child. Okay, so just getting into the mode of what is articular and what is periarticular. So coming to definition of arthritis. So I'm not taking questions because it will take a lot of time. So you have to understand when the child comes to you and complains of joint pain, what you're seeing is arthralgia. When you see and examine, then you have to identify whether you are just dealing with arthralgia or you are dealing with arthritis. So in any question or when you are dealing with a case also, you need to find out whether you are dealing with arthritis or arthralgia. So if the child complains that with pain, there is a swelling of the joint, then you understand that you're dealing with arthritis. Or if with that pain, there is limitation of joint movements. In a chronic arthritis, there will be limitation of joint movements. The range of movements will get restricted. Or in an acute situation, you will see signs of inflammation. So heat, warmth overlying the joint. Then you are dealing with something which defines a child to have arthritis. So do not confuse between arthralgia and arthritis. A lot of other things where there is a vitamin deficiency or iron deficiency or anemia, where the child may have just arthralgia and they may complain of joint pain. So it's more of arthralgia. So now supposedly you see a child is having pain and you feel that the child is having arthritis. When you see the child, you need to answer few questions to yourself. What are these questions? Whether you are dealing with an articular pain or a periarticular pain. whether you are dealing with an inflammatory joint pain or a non-inflammatory joint swelling, whether you are dealing with an acute case. So I think it was the wrong way. At first you define yourself whether you're dealing with acute or a chronic, then inflammatory, non-inflammatory, articular, non-articular, and then you see pointers to find out one differential diagnosis. Whenever you see a case, you will need to have a differential diagnosis. So which joint are involved, how many joints are involved, what is the age group of the joint. These are key pointers which will help you to identify or make a differential diagnosis. Okay, whenever you're seeing a case in the OPD or of course in the exams, which is important. Coming one by one to each point. So articular versus periarticular. Right now in the first picture, we saw what is periarticular. So if the child is complaining of pain, which is arising from the tendon, bursa, ligament, muscle, bone. So these are periarticular pain. So now just imagine this is your knee joint, your quadriceps is coming and attaching to the tibial tuberosity. अगर tibial tuberosity में कुछ pain हुआ, तो patient will, when you examine the patient, pain will be at the tuberosity. It will be a focal pain which the child will complain. But अगर joint के अंदर है, so then it will be a diffuse pain. All movements when the child will do इधर किया उधर किया ऐसे किया वैसे किया, all movements will be painful. But if it's tibial tuberosity ka bursitis, only when he is flexing extension, so then it is using the quadriceps, that will be painful. So you need to identify that. So here, if you see a focal pain, if you see a focal thing, if you see it is in a few planes of movement, pain is there, then that is a periarticular joint swelling. But if you see it's a very diffuse, deep pain, and it is in all planes of movements, then the chances of an articular pain is common. In pediatric age group, sports injury are less common. So periarticular pain are less common, except in few varieties where we see enthesitis. Then periarticular pain arises. Otherwise, more commonly, it is articular pain. So first, we differentiate whether we are dealing with a joint problem or a periarticular problem. Next, we are dealing whether this pain is an inflammatory or non-inflammatory in nature. So we all know when there is an inflammatory joint pain, you will have early morning stiffness, you will have swelling, you will have erythema, you will have signs of inflammation, and there will be some systemic features. Okay, so fever may be present, generalized weakness may be present, weight loss may be present, systemic features which are present in inflammatory joint pain. Now you imagine a patient of skeletal dysplasia. So if there is a skeletal dysplasia, or like we see Perthes disease or skiffy, or there is an avascular necrosis of the head of the femur, that child will also complain of significant pain, but that will be non-inflammatory. Usko bukhar nahi aa raha hoga, uska weight loss nahi ho raha hoga, but pain hoga, limping hoga. So all these things, that is early morning stiffness, swelling, erythema, warmth, will be absent in these patients. And when you investigate, the ESR-CRP will not be high. So that is how you will differentiate between clinically first the initial symptoms. So remember, whenever you are seeing a child with joint pain, a very important history to take is whether you have a morning pain, whether you have pain throughout the day, whether you have evening pain, and whether you have night pain. So can anybody just tell if you have a night pain? Just put it in the chat box. If you have a night pain, what is a very important fever and night pain? Then what is one thing that it should strike to your mind? Or if the examiner is asking you what is should anybody can unmute also and tell. So I see a lot of people putting very correct answers here. So of course, when you see a patient who's complaining of night pain, bukhar hai na, then that time it is chances of malignancy. Always remember systemic features are there. रात में sometimes growing pain भी सोते समय होता है. लेकिन of course, this we are discussing about a joint, inflammatory joint pain. Very good. So that time you have to think of malignancy. Coming to the first, which I should have discussed, acute versus chronic. So how do you differentiate between acute chronic? Again, chat box mein, what is the duration where you say it is acute disease and then a chronic disease in case of arthritis? Anybody who wants to put it in the chat box, ki, what is the duration? Yes, so acute is less than 6 weeks. So less than 6 weeks pain usually is there's no sacrosanct line when you're seeing the patient, but of course when you're defining it, more than 6 weeks will define as a chronic joint problem or a chronic arthritis. Less than 6 weeks is acute or subacute. Now this category, This is less than 2 weeks. Subacute becomes 2 to 6 weeks, and more than 6 weeks becomes a chronic joint pain. So when there is an absolutely acute within few days to few weeks, then you think of a septic arthritis. So it's very important differential diagnosis. Child sick looking with fever, single joint swelling, and unable to move the joint at all within a few days, 2 3 days, or there is a history of boil in the past, then you think that there is a bacterial cause to it, a septic arthritis or spilling over from an osteomyelitis. Second is if there is a trauma, gir gaya bacha, lag gaya. And third is coagulopathy. So young male child, then if there is a swelling of the joint, then you understand that there can be hemophilia as a cause. So coagulopathies can be a cause. So three important differential that you should always remember when you see acute is bacterial, trauma, and coagulopathies. Then all which are going to start as chronic can be a subacute. So in start of JIA, an important part there you have to think of rheumatic fever, then neoplasias, like you already said, that there is malignancy which can present with arthritis. So three things when you're saying acute versus chronic, articular versus periarticular, and inflammatory versus non-inflammatory. Then in all these, what will be the differential will be through two pointers like age kya hai bacche ka. If supposedly JIA hai, तो which variety of JIA, younger age group hai, adolescent age group hai, male hai, female hai, what is the duration, symmetrical joints involvement hai, small symmetrical joint involvement, which are the joints involvement, peripheral joint involvement, large joint, peripheral small joint involvement, large joint involvement, root joint or axial. So the hip joint or the shoulder joint become a root joint, and axial is the sacroiliac joint. These become the axial joint involvement. So whether this is there or not, that you have to see. Migratory, we all know, we see migratory arthritis possibility in rheumatic fever. Then you see whether it is deforming, non-deforming. This I've already discussed, number, large or small, axial, peripheral or root joints. Then associated features, whether there is rash, whether there is uveitis associated or not. Okay, so here this helps you to reach to a differential diagnosis when you are seeing a case of arthritis. So what I've noticed is approach to monoarthritis, approach to polyarthritis, both come as questions. So in this way, you can have an approach to anything, mono also and poly also. Coming to when you're seeing a child, then PGAS. In this, anybody wants to unmute and ask any question right now? I give just 1 minute to ask any question, or you can put in the chat box also if there is any question. Okay, so we'll go ahead. PGALS examination. So PGALS examination, of course, it's more practical to demonstrate a PGALS examination, but always remember that PGALS examination is very important whenever you see any clumsy child. Okay, remember it is a screening examination. It is not like कि अगर बच्चे को elbow का pain है तो elbow का PGALS करना है. The whole body का PGALS. It's a screening which can be done with a child. If you have a good rapport with the child over 4 years of age, it should take only 2 minutes. Always before doing a PGALS examination, you should remember the normal milestones. Motor milestones क्या है, बच्चा बैठेगा कब, उठेगा कब, चलेगा कब, normal चलना कब start होगा. So they say कि even the child is toe walking or maybe there is some abnormality, flat feet hai, so till 7 years you at least wait till labeling them as a abnormal finding, until unless you find asymmetry. Then asymmetry hai, so of course you feel that this is abnormality here. So you need to know all these gait patterns. We will directly go to PGALS examination. So PGALS examination, first thing is pediatric gait, arm, leg, spine. So we'll see the patient standing. So if the patient is standing, we'll observe from the front, back, and from the side and try and undress as much as possible. And we'll first observe the child from all directions to see if there is how is the whole examination. Then we will ask the child to walk. So the child will walk straight. Then we'll ask the child to walk on the heels and we'll ask the child to walk on the toes. Okay, so walk normally, where you will see symmetrically walk कर रहा है, नहीं कर रहा है, limp कर रहा है, एक तरफ झुक रहा है, नहीं झुक रहा है. Then we'll ask on the toes and we'll ask on the heel. So this is different from the adult GALS. Adult में it is not done. And while we are doing this, we examine the whole ankle. Kind of, we are screening the ankle with it. Okay. After gait, we come to the arms. So arms. So all those whose videos are on, you will start first with the namaste. Okay. So you will do this, you will do this. Okay. All can do it so that they don't need a rheumatologist. Then ulta. Then we stretch the arms and make a fist. Then there is this manual dexterity. Okay, so touching the tip and the thumb tip and the fingertip. Okay, then press on the metacarpophalangeal joints. While you're doing this, you're doing the interphalangeal. Then press on the metacarpo. Don't press on the interphalangeal joint. Press on the metacarpophalangeal joints. Understood? Okay, so this is the P guides, and then we stretch the arm. So if you see, first is this, then fist is there, then manual dexterity, then this is doing the metacarpophalangeal joint, then namaste. This is also not done in adult gals. Okay, this position is not done. This position and this position is not done in adult. Then stretch the arms. So here you see the shoulder movement. So as the child goes up, sometimes the prominent joint may not be shoulder, but later when you do the GALS examination, you realize shoulder is involvement, and then back. So these 8 movements help you to examine the wrist, the smaller joints of the hands, the elbow, the shoulder. Complete examination is done. A screening examination is done with P-GAL screening of the arms. Okay, coming to the next, we do the legs. So as we have done the arms, now we have already examined the ankles. So we are left with the knee and the hip. So you see in this one, they are making the child lying down, and in lying down position, a patellar tap can be done to see fluid, or you always remember we push the fluid from up to down. So suprapatellar area mein commonest hota hai. So you push it down and then you try to move it, whether this patella is moving inside the fluid or not. So you examine whether there is fluid inside or not, and you feel that there is an effusion inside. Then you do the movements where he is bringing in this part, the leg part comes out, and the second is leg part goes in. So this helps you examine the hip and the SI joints. So you see the leg part going in, and in this one you see the leg part going out. So here you can examine both the hip and the SI joint. When you move the leg out, the hip moves inside. When you move the leg inside, the hip moves outside. So this is how you examine the hip and the SI joint movement. So this is the leg examination. Coming to the spine examination. So this one we have already done. So this gives you a spine examination when you're doing up and down movement of the neck. So this will cervical spine examination. So side by side movements, up and down movements, you have already observed when you were seeing the back. And this position, you see the lumbar lordosis. This is very important because in cases of axial joint involvement, this can be affected. So they used to say that you can see when you're seeing a patient of enthesitis related arthritis who have axial involvement, then the floor to finger distance can be measured. And as the child gets better, the floor to finger distance reduces. But anyways, this is not very important at this point. And one more thing is 3 fingers and R. So we see the temporomandibular joint in cases of pediatric gulls. So this is another thing that we have to see. So your kids own 3 fingers in a vertical. Don't do like this. So in a vertical position should be able to go inside the mouth. This is pediatric gait, arm, leg, spine, screen. Very important for exam purpose, also very important in clinical practice when you're seeing any child with joint pain or a clumsy child. So they say it's not necessarily only joint. If there is a clumsy child, maybe a neurological or neuromuscular problem, then also a P-GAL screening can be done. Okay, and it should take only just 2 minutes when you're seeing in the OPD a patient. So this is about P-GAL screening. Coming to the next part, coming to the part of now we have done that, we have seen there is arthritis, we have done an examination, and supposedly we come down to juvenile idiopathic arthritis. So juvenile idiopathic arthritis, I'll take a brief. So whenever you write short note, what are the topics on which you write a short note on? Supposedly you have to write a short note on GI. What would you write the topics? First you will do definition, then Bhumika, would you like to unmute and tell? So फंसा दिया भूमिका को ना. So we'll do a definition, we'll do classification, then we will do in clinical features, then investigation, and then in treatment. Whenever you write a short note in anything, for example, for anything, you start with definition. So what is the definition of juvenile idiopathic arthritis? Okay, arthritis in one or more joint in a child who is less than 16 years of age group, for a duration of more than 6 weeks. 6 weeks we have already defined chronic ho gaya. So juvenile idiopathic arthritis is the most common cause of chronic arthritis in pediatric age group. Less than 16 years, more than 6 weeks, one or more than one. So it's not required कि बहुत सारा joint होना चाहिए तो JIA बताएंगे उसको. One or more than one joint becomes juvenile idiopathic arthritis. This is the definition. Coming to the classification. So there are two classifications because 2023 Printo gave a newer classification. So I feel you should know that also. The first is International League Against Rheumatology classification and second is a Printo classification. In the first classification, which is the most commonly used classification, I think somebody had put in the chat box also about that classification. So there are 7 categories of classification. Systemic means systemic मतलब बुखार के साथ आएगा, systemic features के साथ आएगा. Enthesitis related arthritis, always remember older age group में आएगा, axial या larger joints में आएगा. Psoriatic, then oligoarticular, polyarticular, RF positive, polyarticular, RF negative, and undifferentiated. So again on the chat box, how many joints for oligoarticular? To define oligoarticular. No answers. How many joints to define oligoarticular? So this is why I wanted, because there is a lot of confusion. Somebody has written less than 4, 4 or less than 4. So 4 or less than 4 is the correct answer. Okay, not less than 4. So 4 is also oligoarticular. Though it is very ridiculous to say कि 4 हो गया तो oligo हो गया और 5 हो गया तो poly हो गया. But definition wise, it is this way only. 4 or less than 4. Okay, so this is less than equal to 5 can be said. Less than equal to 4, sorry. Less than equal to 4 can be said here, which is oligoarticular. Polyarticular, anything which is more than equal to 5 becomes polyarticular JI. Okay. In oligo, there is one as extended and one is persistent. So what they say, after 6 months, if you say, okay, there is more joint involvement, then you say that these patients have become extended oligo, which behave like a polyarticular GI. Okay, so systemic, era, psoriatic, oligo, poly RF positive, poly RF negative, and undifferentiated. किसी में भी fit नहीं हुआ, undifferentiated हो गया. Now the problem with this is, one, it is number dependent. Second, it is duration dependent. So Printo said that we don't want these kind of number dependent and duration dependent. There is no homogeneity. There is psoriatic, which is different. And then if you go actually to the list, then there should be no RIF. There are a lot of exclusion criteria where they have defined with each category. So they said we want a simpler classification, which is easier. So they put it into 5 categories. Systemic was there. Systemic remains here also. So systemic is the same systemic category, which was there also, here also. Era was there also, here also. So 2 categories remain same. Now we had 1 category of RF positive, which comes here also. Second category they have put, which is a pediatric age group, early onset, means less than 6 years, ANA positive disease. Rest everything, be it psoriatic, be it others, they have put it in others category. Supposedly ANA negative, RF negative, it will come in others category. Okay, so 5 category: systemic, era, early onset ANA positive, RF positive, and others, which is the Printo newer 2023 classification. This is the European group. So you should remember both, because in exams you may be asked about oligo also. Oligo, poly kya hai, if you get a case of arthritis. So this is a very busy slide showing all the newer classification. We'll not go into the details of it. I will just come to the clinical features. So you define it, then you classify it. Then after classification, this is the differences between this. One thing here, that Printo has made it less than 18 years as pediatric age group, less than 18 years. This we have already discussed, the 5 category and the 7 categories here. We have already discussed that this is not dependent on the number of joints, whereas ILR is dependent on the number of joints. And here the early onset is a specific category, which is a pediatric age group, less than 6 years category. Systemic onset JIA, we will come to the definition of Printo. So initially, arthritis was a compulsory criteria in ILR, but in Printo, they have said that arthritis is not a compulsory criteria. You can still diagnose a systemic onset arthritis. So coming to the clinical features of systemic arthritis I have put first. So here you have to remember, we have defined arthritis as 6 weeks duration. But in systemic arthritis, 2 weeks duration, 3 days continuous fever. So fever which is for 2 weeks duration and at least 3 days continuous quotidian fever is there, can define as can be classified in the category of systemic arthritis. There has to be two things. Along with fever, they need to have one major, either one major. So major is rash. We know it's an evanescent rash. The most important word that you should use in write in your exam, use and should know about it, that it's an evanescent rash. Fever आएगा, पूरा body rash में आएगा, fever चला गया, rash चला जाएगा. It's very typical of systemic arthritis, evanescent rash. And second is arthritis. So rash with arthritis, if it is there, then this one of the major criteria. Second is out of the, or if there is no major, then two minor criteria should be there. So minor में hepatomegaly or splenomegaly or lymphadenopathy. So hepato or and spleno or and lymphadenopathy. Serositis, arthralgia if there is no arthritis, and leukocytosis. So either of any of the two of the minor criteria are present, then you can consider that this is systemic onset arthritis. And complications like mass and lung diseases can happen with systemic arthritis. Always remember, systemic arthritis is the diagnosis of exclusion. A very close differential to systemic arthritis is leukemia or malignancy, and there are a lot of other systemic diseases, infections, which can present like fever with joint pain, with joint swelling. So you should always rule out other diseases and then only consider that this is a systemic arthritis. Okay. And when a systemic arthritis is suspected and the child is getting sick, so you always should know that you need to suspect mass, because it is the first presentation of systemic arthritis where the child can land up in mass. Where you, in a diagnosed case, it is easy. Bukhar aa raha hai na, usko mass ho gaya hoga. But in an undiagnosed case, first time presentation, mass can be there. So if you see a quotidian fever which is getting daily, if you see an ESR which is falling, if you see thrombocytopenia, leukopenia, whereas it should be actually thrombocytosis, leukocytosis, and a very high ferritin level. So I always, you should understand why does the ESR fall in cases of mass. So ESR, when you take in a tube, the Rolu formation happens of the RBC and upper part is the ESR. So this is the ESR. Now ESR, this sedimentation or the Rolu formation is helped with the fibrinogen. Here in mass, it's a consumption problem. So the fibrinogen reduced. So Rolu nahi banega, to the RBCs will not form Rolu, the upper part will reduce. So the ESR reduces in cases of mass. Because fibrinogen nahi hai, Rolu nahi bana raha hai, so ESR fall हो जाएगा, but CRP बढ़ जाएगा. So ऐसा नहीं है ESR fall हो गया तो we'll get happy, हाँ बच्चा अच्छा हो रहा है, but बच्चे को बुखार आ रहा है, CRP बढ़ रहा है और ESR fall हो रहा है, it's a red flag sign. CRP and ESR going hand in hand, you are happy. CRP and ESR in ulta directions. So ESR falling, CRP high, that indicates कि mass हो सकता है, significant inflammation हो रहा है, या फिर in certain cases autoimmune disorders CRP is low and ESR is very high. For lupus ho gaya, juvenile dermatomyositis ho gaya, these are categories where the ESR is very high and CRP is not as much high. Okay, so this is when a child who has fever is getting sicker, but the ESR is getting better, then suspect macrophage activation syndrome. That can be a possibility. Okay, so we have gone to the clinical features of systemic onset GIA. Oligoarthritis. Somebody has, I'll just answer the question here only. Somebody has put a very pertinent question, very important question of HLH versus mass. So mass, I'm not going to the whole the criteria one by one, but even if in a child with systemic onset arthritis, when you start seeing the platelet count falling, so in HLH, the 1.8, less than 1.8 is the platelet here, but here the 2.7 se kam hua platelet criteria, then also mass criteria happens. So HLH is usually a primary disease or genetic disease. Mass can happen with infection or with systemic onset arthritis, and all things need not fit clinically to diagnose mass. Treatment wise, essentially HLH and mass will have the same treatment unless this is the genetic condition. Okay. Oligoarthritis, coming to oligoarthritis. So here 2-3 things you should remember. It's a toddler age group. So normally it is always considered कि बड़ा बच्चा होगा तो arthritis होगा, but no, you should know the age group. So if you have a male is to female ratio is comparatively जितना poly में होता है उतना difference नहीं है. 2 to 4 years of age group, extended persistent we have already discussed, and large joint involvement. So knee is one of the commonest joint which gets involvement. Most commonly they are ANA positive oligo ones, And uveitis, chronic anterior asymptomatic uveitis, is one of the commoner complications of oligoarticular GI, ANA positive oligoarticular GI. 2 to 4 years, large joint involvement. पॉली बाई मॉडल एज ग्रुप, छोटा वाला छोटा ही जो आरएफ नेगेटिव है, आरएफ नेगेटिव वाला वेराइटी है, दैट इज यूजुअली 2 to 4 years. आरएफ पॉजिटिव वाला वेराइटी यूजुअली लेट ऑनसेट एडल्ट एडोलेसेंट ऑनसेट. RF positive will behave like an adult disease, peripheral small joint involvement. Okay. And RF negative can have small also, large also. They are RF negative, they have fewer erosions, and they have more systemic manifestations, fever and all. But RF positive ko more of arthritic manifestations hoga. They do not have main jada systemic manifestations. Okay. I'm not in detail the other one. Psoriatic, you should always see dactylitis, nail pitting, and history of psoriasis in relative. एरा इज एन इंपॉर्टेंट कैटेगरी. रिमेंबर, इसमें मेल्स ज्यादा कॉमन है. लार्ज जॉइंट and or axial joint can get involved, and you should see the points of insertion of tendons and muscles because they can have enthesitis, so Achilles insertion, plantar fasciitis, all this should be seen. They usually have a symptomatic acute anterior uveitis. Okay. When it is not fitting into anything or fitting into two or more, then you have undifferentiated category. So now one by one, I will ask one of you to unmute and answer. So who are there present now? Manas, will you answer? Which one is this one? Which do you think is this one? Which will be this one? So this is a child who is having large joint involvement, elbow hai, knee hai. So which category can be this? Chota bacha, 2 to 4 years, who is having this? Yes, so I couldn't hear you, but I couldn't see that you are guessing it right. So it is an oligoarticular GI, which can be there. Okay, so oligoarticular GI. So this is how you can identify. Okay, so who else? Margi, are you there? I can see Margi. Will you like to unmute? Anybody else? Or anybody else would like to unmute and talk? Who is there with Bhumika sitting?
Ma'am, first
First,
year, the new is.
oh God, they know too much. Huh? When they know too much, then you will get scared. First years usually know more than second years because they have really read everything. Okay, so anybody, will you guess, Bhumika, this one? This is supposedly a child with axial joint also and maybe a large joint also.
Ma'am, ERA, enthesitis related. Hello.
Axial joint किसमें हो सकता है? Frozen, I think she's frozen. Anybody wants to put in the chat box this one? Or can you hear me? Era, can you hear me? Say
Yes, yes, we can
me,
hear you, Sikha.
because I think this is frozen. I think if we mute, I think.
Sikha, are you there? Sikha, I think she has. uh, I'll just call her up and ask.
Yes, yes. Can you hear me? Am I audible now?
Yes, you are audible.
And now is my screen seen? Screen seen now?
Yes, Sikha.
Okay, so I had to log out from one device. I was actually logging in from two devices. So now it's good that I'll not be able to ask any questions to anybody. Okay, so here we will see just this one. This is the large joint involvement. If you see, this is, one second. So this is the large joint involvement, small bachu. So we'll have oligoarthritis, axial joint involvement, then the chances of enthesitis related arthritis. Peripheral joint, only small peripheral joint, then RF positive disease chances are there. Systemic features, fever is there, so systemic arthritis is there. This is how you can differentiate. Coming to the investigation, so we always say the first investigation is first, and do not say as inflammatory markers as serum ferritin. The inflammatory markers will always be C-reactive protein and ESR initially. CBC, coagulation profile, you should say when you see a small bachu with single joint involvement, male child, then you should say coagulation profile. Okay, then coming to the investigations, what will you see? Hemoglobin may be low, anemia of chronic disease, WBC may be high, platelet counts may be high, ESR, CRP high. If you're seeing systemic onset GI and you have suspected that, ferritin may be high in that case. Remember, the most common antibody detected will be ANA. So oligoarticular ho ya others ho, we usually do an ANA, and ANA doesn't have a specific pattern here. So it can be anti-histone or any other pattern, but not like dsDNA or anti-Smith, which we usually see with systemic autoimmune disorders. So remember about that also, that we do not see in this. Okay, rarest antibodies RF. So
Recording in
whenever
progress.
one second. Okay, so the rarest antibody is RF. So whenever we do whenever we do RF test, we should be very careful when we are doing it and why we are doing it, because it gives a false sense of security both to us that the child doesn't have arthritis and even to the parents that the child may not have arthritis. Okay. Okay, after investigations, we can do imaging findings. Remember, X-ray, USG is a very important imaging finding, because when you do a Doppler screen, then you can see whether there is an active vasculitis or not. You should always, as a PG student, remember what are the X-ray findings. Erosions, if you see, then chances of osteomyelitis, septic arthritis is very high, because erosions are very late feature in case of pediatric arthritis. You can see ankylosis in case of especially enthesitis related arthritis. Early fusions and growth issues can happen in case of pediatric JI. Okay, so coming to this again, what investigation you will do? So in all these categories, I will always do a CRP ESR. But when I'm seeing only enthesitis related arthritis, I will like to do an HLA-B27 test. Otherwise, I would not do in other categories. In most of these categories, I would like to do an ANA test. And only when I see more than 5 joint or a peripheral symmetric joint, then I would like to do an RF test. So this is how you will identify and decide about the investigations that you should do, not like a panel investigation ki uric acid bhi kar diya har bacche mein. That should not be done. So here you see ANA, one is CRP ESR in all, ANA and RF only in when you are seeing that there is peripheral symmetric joint involvement. So in these two categories you do, and in this axial joint we do an HLA-B27 test also. Okay, complications क्या होगा? First joint disease है. Complications means you will write about the skeletal complications that you can have. So skeletal complications में you will have growth stunting, limb length increase initial stage में, and later it can decrease once there is an ankylosis. Cervical spine involvement है तो fusion हो सकते हैं, later जाके osteoporosis दिख सकता है. TM joint involvement है तो retrognathia हो सकता है, facial asymmetric हो सकती है. Very important complication in all chronic diseases, endocrinal. So pubertal growth spurts may get affected. So a lot of times when there is an adolescent child with arthritis, when we ask about their normal, whether they have attained menarche, so they attain menarche, and then there are irregular cycles which can happen in these patients. So you should say endocrinal problems which can happen. Important complication which we've already discussed is about the ocular complication, one of the most common extraarticular complication. Two things you should remember in this: chronic anterior uveitis, acute anterior uveitis. First is आगे का ये पूरा जो आंख है उसके सिर्फ आगे एंटीरियर यूवियाइटिस होता है इन सब में. पोस्टीरियर पार्ट और रेटिना विल नॉट गेट इन्वॉल्व्ड इन केसेस ऑफ जेआई. दिस इज नॉट इन्वॉल्व्ड. ओके. In the anterior uveitis, you have to understand one is chronic anterior uveitis. So we always send them to ophthalmologist initially, and ideally if it is an ANA positive less than 7-year-old child oligoarticular disease, the child should have at least 6 monthly follow-up with the ophthalmologist to rule out, because they will have asymptomatic disease. It's very important. They will not have symptoms. Asymptomatic disease, and it can affect bilateral eye and then can lead to synecdoche also. So vision issues. Only in the ERA variety, they have acute symptomatic anterior uveitis, which complains of a red eye. And it's called alternating because it can unilateral हो सकता है, कभी इस आंख में कभी उस आंख में हो सकता है, and usually बड़ा बच्चा होता है, so later age group में usually होता है. There can be steroid related complications and uveitis related complications which can develop in the eye in these patients. Others are psychosocial complications specific to systemic GI. This is a very rarely, I think I have only one or two patients who have developed amyloidosis of the kidney because they have not taken treatment, and especially an ankylosing spondylitis, this can develop. Okay, so uveitis screen important. I've already covered that if there is a less than 7-year-old child, duration of less than 4 years, ANA positive disease, then oligoarticular, then you should do this. Rest 6 to 12 monthly. What are the treatment? We did definition, we did classification, then we did clinical features where you should write commonest age group with gender with joint. So this is how you should write in your clinical features. Third is write or know in the clinical features. Investigations, always blood investigations, then imaging investigations, X-ray versus sonography, and then about the specific antibody test. So when ANA, when RF should be done, and whether imaging is required, MRI is required or not. Okay, coming to the treatment. So treatment, if you see, there is important is NSAIDs in all patients initially you do. Steroid, you should not think that this is the mainstay of therapy and should never tell that that is the mainstay of therapy. 4 forms of steroid can be used. One is a local treatment. So local topical in the eyes can be required for uveitis. Psoriasis hai, so topical on the skin can be required. Then if there is a single monoarticular or just 2 joint involvement in oligoarticular disease, then you advise a local intra-articular joint injection, which is usually triamcinolone hexaacetonide. Hexa is also available in India now, so hexaacetonide can be done, but maximum 3 per year. If you need more than this, then you know that your joint injections are not adequate and you need to immunosuppress them. Certain cases needs a बहुत sick बच्चा है, bridge oral steroids only in systemic arthritis with mass or systemic arthritis where you need IV steroid. DMARD, methotrexate and sulfasalazine. Sulfasalazine works better with cases of enthesitis related arthritis. Biologics, I think if I start taking, it's a full chapter in itself, biologics. So you need to know only a few things I will write here. One is anti-IL-1, which is anakinra for systemic onset arthritis, not available in India. Since not available, we use anti-IL-6. And the rest is anti-TNF molecule. So this is what you should at least write in a case of GI. But biologics also come as a long question or short note also. That is a separate thing. Everything you'll have to write. So here you mention about anti-TNF molecule, which is subcutaneously, which can be given adalimumab, IV, which is given, which is infliximab. Okay, so those things you have to mention in biologics. So coming to treatment, first NSA, steroid, which is not the long-term treatment except in case of systemic arthritis. DMARD, methotrexate, conventional DMARD. So there are 3 DMARDs: C DMARD, B DMARD, biologic, and target synthetic DMARD. So conventional and methotrexate sulfasalazine. Biologics mein you will write about anti-TNF and anti-IL-6 molecule. And target synthetic molecules are small molecules, that is JAK-STAT inhibitors, that is tofacitinib or baricitinib, which are very commonly used now in pediatrics also. Wholesome treatment should be remembered. Ophthalmic screen, like we have already mentioned. Physiotherapy. So even in an active inflammation, light physiotherapy is advised. No bed rest until there is an impending fracture. Then counsel regarding the use of calcium and vitamin D. It's a bone loss osteoclastic activity, so you need extra doses of calcium and vitamin D should be monitored. Drug side effects should be counseled to these patients. Okay, and finally, the treatment response should be seen. So this is what we will do. Then coming to the case. So we will see if we can identify these cases here. 6 years old girl child. This is child is presenting of pain in bilateral hands and ankles. So what do we ask? We always used to remember like an OPD, onset, progression, duration. We will ask, right? Onset, progression, and duration of this child. So if I say 6 years old girl child hai, bilateral hand and ankle for 20 days. So what do you think? It is acute or chronic? Anybody can unmute now if anybody wants to unmute. Yes, so we are getting answers on the group, chat. Acute. So less than 6 weeks, acute. Now this child is complaining of fever and night symptoms also, tenderness also, swelling and local rise. So arthritis or periarticular? Swelling, range of movements in all planes are affected. So articular, acute articular disease you're dealing with, and there is systemic signs also. The further examination, then you see cervical lymph nodes, hepatosplenomegaly. So what you will classify is acute polyarticular systemic disease. And then you will consider your differential diagnosis. So 20 days means kind of beyond two weeks. So we think not of septic arthritis here. Septic arthritis will not come in multiple joints, bilateral hand, ya ankle mein pain nahi hoga, ya ankle ka swelling nahi hoga. So septic arthritis out, trauma is out, okay, coagulopathies is out. So we are left with the other. So your possibilities of malignancy is there, then rheumatic fever is there, all these which are subacute variety. Here we get that there is night symptom, there is fever, there is reticular endothelial system is involved, cervical lymph nodes, hepatomegaly, the chances of malignancy being there is very high. So acute polyarticular systemic, this is when you are summarizing your history or when you're thinking in your mind ki kya differential ho sakta hai, you should summarize yourself. Okay, 6 years, same 6 years old child, if I say कि bilateral hand and ankles में 2 years से problem है, significant morning stiffness है, tenderness है, local rise of temperature, swelling, range of movements restricted है. So again, this is chronic. This is also polyarticular. And this is also having some systemic manifestations in the form of, there is no systemic manifestation, there is no fever, nothing here. So here we are, systemic examination is normal. So here we are dealing with chronic, range of movements is restricted, deforming, polyarticular, but inflammatory disease, morning stiffness hai. So here your differential diagnosis with juvenile idiopathic arthritis. 2 साल का history में most commonly अगर inflammatory है, you have to rule out non-inflammatory causes, because 2 years का history में non-inflammatory causes of dysplasias and all can also be there. So you should rule that out. Okay. So once again, final recall. Young girl, lower limb, few joints. Chat box answers. What will be your difference? Young girl, 2 to 3 years of girl, lower limb, few joint involved. 2 to 4 years की girl child है, lower limb में knee joint का involvement है, few joints involvement है, oligoarticular GI. Good. Here you will always screen for ANA and you will screen for uveitis. Always remember that. Old boy, again lower limb. Old boy है, adolescent boy है, large joint involvement है, knee का swelling है, मतलब few joint है, 1 or 2 joint का involvement है. You will think of HLA-B27 related arthritis, enthesitis related. So usually they say that enthesitis related arthritis is more common in boy, though we see a lot of females also. So error. Acute symptomatic uveitis is that. Only one category which has a symptomatic uveitis. Adolescent girl, multiple small and large joints, so multiple peripheral small joint involvement, polyarticular GI. So deforming arthritis, RF positive chances are higher in these cases. Usually large itna nahi hota hai, though isme I mentioned large also, usually large RF positive mein nahi hota hai. Poor prognosis. Any age, high grade fever, evanescent rash. So here you will think of systemic onset arthritis. Okay, diagnosis of exclusion. Always remember that. Okay, study the pattern, associated systemic features. They often guide us to the diagnosis of each child. Okay, can you see these joints? So you see here in this child. So this is different. This one is different and this one is different. I have particularly. So if this child you see, if this one you see, the second picture you see, Here you see the wrist is involved and proximal interphalangeal joints are involved, but the distal are not involved. So this child being a polyarticular RF positive disease is very common because this is here. Here, if you see, this child is actually a skeletal dysplasia, progressive pseudo-rheumatoid dysplasia. He has both this and this joint involvement. So asymmetric peripheral joint can be in psoriatic also, but there are certain mimickers of arthritis which can present like this. So you see कि सब involved है, but इसको arthritis नहीं है. It's actually when you examine, then only you can understand कि fluid नहीं है अंदर. It's just that the joints are enlarged. So this is a dysplasia here. Okay. This one, if you see, this child had complained only of knee pain. But later when you see, if you see the nails, if you can see here, and if you can see the plantar area, if you can see. So this child had nail pitting and nail involvement. This child had a family history of psoriasis. So पूछना पड़ता है कि psoriasis है किसी को family में. So this child had psoriatic arthritis. Okay. This is reactive arthritis. So you uncover and examine. This was a reactive arthritis, keratoderma benorhagicum, which a child has, a lesion which can happen with reactive arthritis. Okay, and this is if you see there is some rash, if you can identify the rash here, evanescent rash with high spiking fever. So this is a child with systemic onset arthritis. Okay. So you can ask any questions if you know. Now we are finished in still 3 minutes left.
Any questions, students? Sikha madam has really taken through in elaborate, but at the same time, very, very simplified and crisp form of approaching a pediatric rheumatological condition, most commonly the joint that we come across, not just exam oriented, but also as a general pediatrician in routine office practice. An approach to a joint, a painful or a painless, with or without swelling, is the commonest thing that we encounter. And I think she has very beautifully summed up for us. So, any questions from you all?
So
From
I
any
think
one of you?
HLH
Sikha,
and maths
you
wala
were saying
question was
something.
very relevant. So HLH and maths question was very relevant. I think you should go back to books and read the criteria. It's very different. It is actually confusing, HLH and maths, when you're seeing in clinical practice. If someone, 1 second, I'll just open the chat box.
Sikha,
if someone
only
has
last.
repeated iridocyclitis, then management. So it all depends what is the primary. See here, we deal with a lot of patients with eye symptoms, and we really deal with a lot of ophthalmologists, and they tell us कि chronic hai and acute lag raha hai, kya lag raha hai. Immunosuppression is the thing which needs to be done with iridocyclitis. If it is an autoimmune thing which you're suspecting, trauma has been ruled out, that is not the cause of it, or other causes. And if the ophthalmologists say that it is a chronic seemingly acute autoimmune iridocyclitis, then we need immunosuppression. If it is HLA-B27 positive disease and acute anterior uveitis usko repeated ho raha hai, then also they will need immunosuppression. The only problem with they respond only to anti-TNF molecule. You cannot use steroid. So even if you see, they say that if you have to use more than 2 weeks of topical steroid, then the chances of cataract increases. So you have to be careful that amount of steroid that you're using, even if it is topical. They will need immunosuppression.
Sikha, somebody's asked naproxen test, if you can reply.
So see, I do not believe in that naproxen test. A lot of people give naproxen and they say that if the fever settles, the chances of systemic onset arthritis is very high. But frankly speaking, clinically it is not. You have to clinically identify rather than a naproxen test. I feel any fever, naproxen is an anti-inflammatory. Thoda to kam karega hi bukhar ko. Systemic onset JIA versus leukemia, highly different. Systemic onset JIA is always a diagnosis of exclusion. So systemic onset JIA child is never as sick as a leukemia child. I think it's very easy when you go to a child, the child, if it मतलब बिना बुखार के अगर बच्चा रो रहा है तो वो चांसेस है कि ल्यूकेमिया होगा. मतलब रो रहा है मतलब यू आइडेंटिफाई ऐसे ही नहीं रो रहा है, काइंड ऑफ sick looking है, toxic looking है, ठीक नहीं लग रहा है, तो chances of leukemia is high. So most of the systemic JIA, we try and do the bone marrow, rule out a leukemia, and then only give steroid, because systemic arthritis is the only variety in JIA who needs more steroid compared to anything else. And I think this is very important for these PGs who have joined, that steroids should not be given for a long. It's not the mainstay of treatment in any GI. Bridge steroid can be given, but if you have a slightest of doubt leukemia, do a peripheral smear, see whether the blasts are there or not. If there is any abnormality, do the bone marrow.
Sikha, answer to the last question. Is a bone marrow mandatory before starting steroids?
No, so depending on which condition you are starting. So if I'm thinking of systemic onset arthritis, then I usually get the bone marrow done to rule out, because the duration of steroids is longer duration. But in any other, supposedly if I know it's a polyarticular disease or oligoarticular disease, no fever, nothing, no hepatosplenomegaly, then not at all mandatory to do a bone marrow. Systemic, of course, then we try to do a bone marrow, rule out the leukemia, and then we do it, because it's diagnosis exclusion, not in other GIs.
Great. Any more questions? Should we conclude, Sikha?
Yes, ma'am. Yes.
So, of course, very officially and formally on behalf of Team IAP Mumbai, I'm thanking our secretary, our very dynamic and swift, and of course, as you saw today, a very astute clinician and academician also. She was so crisp and clear and trying to put everything in the nutshell that it was taking me time to register and note and probably again reiterate back. So I was thinking of trying to sum up, but I think she's done it so beautifully that it's so clear. And of course, thanks to all of you for joining in for this meeting today. And just to also announce that IAP Mumbai would be starting the IAP Mumbai's PG Ki Pathshala. Now, this is going to be a physical program.
Ma'am froze. Jagruti ma'am, can you hear Nehal ma'am?
No. I think she's present.
So I'll just tell that this is a physical program, and the first experts would be coming on a specific topic, and it is specially designed for the postgraduate students, so that there is case-based discussion and also theory-based discussion, exam paper-based discussion. So it helps you. One expert will be coming, which will be announced. We have made a group where it will be announced where they will be coming. First topic is on endocrinology. So this month is on endocrinology, and Kasta sir, this is on 29th, right?
Yes.
It's on a Saturday, 29th, from 4 p.m. to 5:30 p.m. So this time it is on endocrinology, and we have Dr. Akanksha Parikh coming. She's amazing. She's very good at her delivery of talk. So I think all PGs should attend that as far as possible. Nehal,
The
ma'am,
flow
you are
is going
muted.
to be, the flow is going to be a 45 minutes of a virtual case discussion and approach to one common problem that is going to be important for the postgraduate students as far as even the exam is concerned, but of course thereafter also in general pediatric practice. And thereafter there's going to be a 15-minute kind of a visual curtain or an OSCE kind of a presentation regarding that entire system, absolute very crisp spotters with bullets that will cover up the entire system. And then thereafter, there is going to be a 15-minute, very objective MCQ type quiz. And the winners are going to be given prizes and IAP Mumbai certificates also. So this is going to be really exciting and interesting. We are going to put up the details every month. Next month onwards, we will try to put up the following 3 months system or this thing in advance. So it will be kind of an incentive for you also to read up a little bit about that and come for it. So do join us, all of you, on the 29th of March at Sion Hospital, PG Seminar Hall, in between 4 and 5:30 p.m. Anything else, Rajesh bhai? Sikha, anything else?
Thank you.
Okay,
Thank you so
great.
much to pediatricians and PGs both for joining in.
Thank you, Sikha, once again. Thank you, all of you, for joining. Good night, all of you.
Good night. Good.
निलेश एंड करू शकते हा मीटिंग